You are able to see my screen?
Yes.
Yes, we
You are
can
able to
see.
see my screen? I can't see it. You know where is it? You can see the slides.
Yes,
Yes.
we can see it.
Okay. So today I don't want us to take much time. I want us to cover the anatomy of the upper limb. Your class complained that they didn't receive the slides on time last time. I just want us to finish. The anatomy of the upper limb can be quite wide, but what you want to do is just to know the must know of the upper limb and leave the details for the people who love anatomy more. Can read them at your own free time. So, mainly for anatomy, we want to know about the surface anatomy of the upper limb, skeleton, the skeleton of the upper limb, that is the osteology. Appreciate the bone, appreciate the parts of the bones, the muscle attachments, and then, of course, the joint of the upper limb. We are mostly interested in the shoulder joint. You are interested in the elbow joint and the wrist joint. Muscles of the upper limb, and finally the nerves. Also, the vascular aspect, which I want you to go and read on it. The arteries, for example. What's happening? You can still see my slides?
No.
Yes?
Yes. We are seeing.
On my slides, they have disappeared.
They are not working.
Pardon?
I'm also not seeing.
Yes, I think now you are good. So don't confuse the arm to the forearm. The arm is the part between the shoulder and the elbow joint, while the forearm is now between the elbow joint. Okay. So for the anatomy of the upper limb, we have the medial epicondyle, lateral epicondyle, that is the prominent parts of the elbow on either sides. The olecranon process is now found on the ulna. Cubital fossa is an important landmark of the upper limb. And you can also appreciate the boundary. For example, this picture shows our cubital fossa, indicating the contents of the cubital fossa. That's when I will ask. Brachioartery and the median nerve. Then the boundaries of the cubital fossa involving the medial aspect, the protenenda teres, lateral brachialis, and the line of the epicondyle. So we'll go again. We want you to know about the carpal tunnel, what makes up the carpal tunnel, and the structures passing through the carpal tunnel. For example, here we've indicated the carpal tunnel contains the median nerve and the long tendons. So which long tendons are these? Normally the flexor digitorum superficialis and the flexor digitorum profundus will also pass through the carpal tunnel. So now the structures pass through the carpal tunnel. The anatomical snap box is that part highlighted in black. We're just doing the surface anatomy first still. This part highlighted in black is called the anatomical snap box, consisting of medial and lateral boundaries, the floor, scaphoid, right stylo process, the radius, medial aspect consisting of, or rather made up by extensor pollicis longus, lateral by extensor pollicis brevis. So this is our skeleton. You can see the attachment of the shoulder joint to the scapula and how it goes all the way to become to make up the elbow joint, where now the two bones take up the skeletal structures, the radius and ulna, and there is the clavicle also part of the upper limb. So the bones of the upper limb consists of the scapula, which also, but people know it as a shoulder blade. You can appreciate different parts of the scapula. When we'll be doing our overviews, we'll get time to, once we finish, think we'll finish today. So most likely next week we can look for a session, even if it's in the afternoon. Divide ourselves into two groups, the nursing group and the physiotherapy, and then we'll be appreciate the different osteology of the upper and the lower limbs to be next week. So most likely on a Friday, be able to do that next week Friday, so that now you give people ample time to go through everything. So you can appreciate the acromion. The acromion is the uppermost part. You can see the coracoid process. You can also appreciate the glenoid fossa, where the head of the humerus sits. Then supraglenoid tubercle, there is a muscle that attaches there as its origin. You must know that. As well as the infraglenoid tubercle. You must know which muscle comes from that part. Then we have the subscapular fossa. That's quite easy. The subscapularis coming from that point. Suprascapular notch, superior border, and the superior angle of the scapula. That is the posterior, the anterior view. Now there's the posterior view, which is the part B. You can see the posterior view has the spine of the scapula, dividing the two fossae of the known as the supraspinous fossa and the infraspinous fossa, which harbor or rather form attachment of the supraspinatus and infraspinatus muscle. That will be our scapula. I want you to familiarize yourself with these parts of the scapula. Bones of the upper limb, till now we have the clavicle. You can see how the medial part is the superior and inferior surfaces, and the anterior and the posterior surfaces. Muscle attachment. We'll also appreciate the scapula. I mean the clavicle in our demonstrations. Then the main bone, which is the humerus, can appreciate the lesser tubercle, the greater tuberosity, or rather, some books call it lesser tubercle, some other call it lesser tuberosity, depending on the book you are using. You have the intertubercular sulcus or the intertubercular groove. There is a tendon that passes all the way, which is the long head of biceps. Brachii tendon passes all the way from the supraglenoid tubercle, and it now also traverses the intertubercular groove. Some books will refer to it as the intertubercular sulcus. You have the surgical neck, anatomical neck. You can see how the head is. The head is well rounded, but the neck is quite short compared to the neck of the femur. Then this is the shaft of the humerus. You can appreciate the lateral epicondyle, medial epicondyle, and the cranial fossa. Ulnar radius, you can see how the ulnar notch is represented very well. Where the humerus attaches there, you can see this part, the capitulum and the trochlea. These are the parts that actually insert into the ulnar fossa, or ulnar notch. Then you can see the cranial fossa on the posterior part of the humerus. So this is the ulnar notch that we talked about. This depression. So you can see the trochlear part of the humerus that attaches there. So radial tuberosity, you can appreciate the radial tuberosity among other parts of the ulna. So make sure you know how the ulna looks like, how the radius look like. We may not ask it not for only for exam purposes, also for now for knowledge. Bones of the hand, you have the carpal bones. How they are arranged is also always important. Which one articulates with what? For example, you have the carpal bones, trapezoid, trapezium, scaphoid, pisiform. Because if you're a physiotherapist, patients will come with pain, like fractures of the scaphoid. Patients will come with pain in the mid-pal pain. Which carpal bone are you suspecting that is causing that mid-pal pain? Must be in a position to tell us. Clinical anatomy related to bones. Of course, we've talked about the clavicle. Before a fall on an outstretched hand, you can get injury, fracture of the clavicle, the middle third aspect. Scapula can give you winging of the scapula, like it fans out or in, depending on the nerve involved. For example, which you'll see later on, the scapula, if it is medial winging, it can mean there's serratus anterior involvement or the lesion. If it is lateral winging, normally it's because of the trapezius. So you must know that. Medial winging, serratus anterior. Lateral winging, that one I will make sure you ask. Muscles of the upper limb. Muscles of the upper limb. Know the muscles on the anterior aspect of the arm, posterior as well, and where they attach for your anatomy orientation. If you're a nurse, when you're scrubbing in with the doctor, you're doing a procedure, you're able to appreciate what you are doing. And if you're a physiotherapist, there's a nerve injury, there's a contracture, you're able to know which contractures that you are dealing with. So the muscles attached on the upper limb, for example, the pectoralis minor, major, and subclavius, they are attached on the trunk, but now also connected to the upper extremities. You must be able to appreciate them and how the nerve supply action, injuries, if any. So at your own free time, I want you to go through these muscles, the pec major, for example, their origin from the sternal half of the clavicle, and also the ribs, and attachment being the lateral lip of the intertubercular sulcus. The intertubercular sulcus is that part we said that the tendon of the long head of the bicep brachia, as you can see, will pass through. So there's this lateral lip, there's this medial. This is the lateral lip, this is the medial lip. So pec major attaches on the lateral lip. The pec minor muscles can appreciate it as well. That normally goes from lib 2, 3, and 4, or other times in some cases, lib 3, 4, 5. That now inserting onto the coracoid process. Subclavius muscle is a tiny muscle originating from first rib of the costochondral junction, inserting into the subclavian groove of the clavicle. Nerve supply C5, C6. So we'll go through them. Of note is this serratus anterior, which we said it causes the winging of the scapula. And blood supply, nerve supply is long thoracic nerve. Winging of the scapula. You can see if someone puts their hand on the wall and exerts some force. If there's a lesion of the serratus anterior or rather a lesion of the long thoracic nerve. We can see the way the scapula is winging on the right side, indicating there is lesion of the long thoracic nerve. So the next is the muscle of the shoulder region. The deltoid, teres major, supraspinatus, infraspinatus, teres minor, subscapularis. So the shoulder region, the last four, as I've indicated, supraspinatus, infra, teres minor, and subscapularis. They are called the rotator cuffs muscle. So you must know what they do. They are now origin, insertion, nerve supply. These are very good MCQ questions there. The following muscles form part of the rotator cuff muscle. And you put teres minor and major there. Then you say minor is not part of the rotator cuff and miss it. So teres major is the one that's not part of the rotator cuff muscle. Teres minor is. So you are guided there. The deltoid is a very important muscle of the upper limb, originating from the third clavicular, third lateral, superior surface of the acromion, the spine of the scapula, inserting into the deltoid tuberosity. Its action is abduction of the arm, flexion and external, and extension of the arm, medial lateral rotation. Supplied by the axillary nerve. C5, C6. C5, C6 are the nerve roots of the axillary nerve. So if you don't have the deltoid, you are unable to raise the arm beyond 15 degrees. Supraspinatus, as you can see, originating from the supraspinatus fossa of the scapula and inserting into the superior facet of the greater tubercle of the humerus. So the humerus, we said it has the greater tubercle, lesser tubercle, median lateral lips of the intertubercular sulcus. You must know what muscles attached there. Infraspinatus, you can appreciate it. There is minor subscapularis. These ones should go through them. Cannot go through them one by one right now. They're well indicated. You can go through them at your own free time. So the movements of the shoulder joint, there are different types of movement of the shoulder joint. So we have flexion, extension, abduction, adduction, internal rotation, external rotation, and circumduction. Circumduction, you understand, is that aspect of moving the arm in 360. That's what circumduction is. So the arm is able to move in 360 while the hip is not able to do circumduction. But some people can do circumduction in some cases. Special guys. So flexion was the pec major, the anterior fibers of the deltoid, and the coracobrachialis. They do you flexion. So you can go through all this. What will give you extension? What will give you abduction, adduction, internal rotation, and external rotation. So muscles of the arm we said is divided into the anterior and posterior compartments. The anterior group fibers consist of the biceps brachii. Biceps brachii has two muscles, the long head and short head, coracobrachialis and the brachialis. Posterior group consisting of tricep brachii muscles, which are three: the long head, medial head, and the lateral head. Don't say now triceps has long head and short head. So you can see the bicep brachii originating all the way from supraglenoid tubercle of the scapula to supraglenoid tubercle of the scapula to the apex of the coracoid, while the short head comes from the apex of the coracoid process and inserting the bicipital aponeurosis, and finally into the radial tuberosity. So this part here that is after the red thing, the red muscle on the right side, that's the bicipital aponeurosis, while on the left side is now inserting into the radiotuberosity. Of course, the main action of the bicep brachii is flexion of the supinated forearm. So nerve supply is musculocutaneous. So the other one is coracobrachialis. You can, as the name suggests, brachialis just means humerus. So from the coracoid process to the inserting into the middle surface of the humerus, main action is to flex and adduct the arm. Blood nerve supply, musculocutaneous nerve. Then you have the brachialis from the distal half of the anterior humerus, inserting into the radial tuberosity. The ulnar tuberosity. Powerful flexion still supplied by the musculocutaneous nerve. So all the muscles of the anterior forearm are supplied by the musculocutaneous nerve, while the muscle of the posterior arm, all of them are normally supplied by the radial nerve. That one you must note. For example, the triceps has long head, medial head, and lateral head, as you have indicated. So the long head the long head is originating from infraglenoid tubercle of the scapula. The lateral head from the oblique ridge on the upper surface above the radial groove, while the medial head from the posterior surface of the humerus. Insertion, all of them coming to, as you can see on the image pictogram, all of them are coming to insert into the olecranon process. The main function of this triceps group of muscles is to cause extension of the forearm, not of the arm, because they are inserting into the olecranon process. So, supplied by the radial nerve C7, C8. So movement at the elbow, you must know the cubital fossa, we already alluded to it. So the movement at the elbow, you only have flexion and extension. Extension is done by the triceps, while flexion is done by the biceps group of muscles. And then you have muscle of the forearm again, which has anterior and posterior compartment. Anterior and posterior compartment. The anterior compartment has superficial and deep. You can appreciate those that are found in the superficial compartment and the ones that are found in the deep. You may not know all the details, but at least go in through what is found. Just know the muscles that are found in the superficial compartment and deep. Here will not belabor you with the origin and insertion, like in the forearm, like in the muscles of the arm. You can see the posterior compartment and corneas. Also, it also has the superficial and deep group. Know what is found in the superficial, what is found in the deep group. We will not belabor with the origin and the insertion, the superficial and deep compartment, but you can just read. Good to know at your level. You can hear me? Are we together? Okay. So movement of the muscle of the forearm, flexion, extension, abduction, adduction, that one is good to know. While the radial ulnar joint, you have supination and pronation. Supination is your arm becomes forward. pronation, your arm, you see the dorsal aspect of the palm. So once when you're showing the palm, that is supination, while pronation is when the palm faces down. Flexion, you can see flexion and extension. Abduction, pronation. So you can appreciate the muscles causing each of the full above movements. Then there is what you call a retinaculum, just like in the foot, and how it comes to form the carpal tunnel. Muscles of the hand, not belabor you with that, but just know also the hand has muscles, the thenar muscles and the hypothenar muscles. Then of importance is the brachial plexus. You should know what this one should be in a position to draw the brachial plexus off head. Yes, you can use your YouTube videos, but make sure you just know how to draw it. You must ask. You cannot escape an upper limb exam without brachial plexus. Note is in the medial cord, lateral cord, C5, C6, C7, C8, T1. So even you can ask about the brachial plexus. The nerve roots extend from C4 to T1, but it's from C5 to T1. Then we ask you the upper trunk. What comes out of the upper trunk, and give you choices. So there are 1,001 questions from brachial plexus. Just go through questions and read around it. In, out, not the nerve. So if you say now the auxiliary nerve is C5, C6, you can see why we are saying C5, C6. C5 is there coming all the way, and like C5, 6, and 6 are combining to come and form the auxiliary nerve here. If you say the radial nerve is C5, C6, C7, C8, you can see why. So we used to say ready to drink. Ready for roots, T for trunk, drink for division, C for cords, then branches. Ready to drink cold beer to guide you on how they are oriented from the roots to the trunk to division, cord, then nerves. So that one, you at your own free time, go through it. The roots, the trunk, division, and the cords. The main branches you can appreciate the lateral cord, medial, and posterior cord. So you can ask you the following branches come from the medial cord, except give you this one. Medial root of the median, ulnar, medial branch of cutaneous nerve, medial branch of whatever, then the radial nerve. So that one you must know. So these are the causes of various nerves of the upper limb. For example, for the median nerve, this is the musculocutaneous nerve distribution, can start with that. Supplies the bicep brachii, brachialis, and coracobrachialis. Then the median nerve. The median nerve supplying the muscles of the forearm. That is, except the brachioradialis, flexor carpi ulnaris, and the ulnar half of the flexor digitorum profundus. That's a very important point. But just know the lesion or injury of the median nerve will give you an ape hand. Ulnar nerve mostly supplies the lumbricus, third and fourth lumbricus, and hypothenar muscles, and flexor carpi ulnaris, ulnar half of the flexor digitorum profundus, the interossei. So the injury of the ulnar nerve will give you claw hand. Radial nerve is what will give you the wrist drop. Mostly supplies the triceps and the cutaneous part of the skin and back of the arm and the palmar surface. I mean back of the hand. That is dorsum of the hand. dorsum of the hand. Injury will give you wrist drop. You'll see many patients as a physiotherapist or as a nurse with wrist drops. Actually, you're able to identify that. Axillary nerve, applying mostly mainly just the deltoid and the teres minor over the deltoid and upper posterior aspect of the arm. Injury results into deltoid and teres minor paralysis, loss of shoulder AB action, and external rotation. So this is our cubital fossa. Cubital fossa is the mid part between the forearm and arm and the elbow, the anterior aspect of the elbow. You can appreciate the contents, boundaries, the cubital fossa. Make sure you know that, because that one will have to ask. Carpal tunnel syndrome, make sure you know the tendons that traverse the carpal tunnel and the nerve that is affecting the carpal tunnel syndrome, which is normally the median nerve. That one will have to ask. So brachial plexus and their injuries, we have something called Ebb's palsy, or the waiter's steep hand, or policeman's steep hand, caused by injury to the C5, C6. Klumpke's palsy, caused by injury of C8, T1, you must know that. Axillary nerve lesion, you must know what happens. Radial nerve will give you wrist drop, as you have alluded. The median nerve will give you the carpal, is normally affected in the carpal tunnel syndrome, and you'll see also thenar atrophy. Ulnar nerve will give you ulnar claw hand. That is the pictorial representation of the wrist drop. You can see that. You can see claw hand, this partial and complete claw hand. Claw hand, that's because of ulnar nerve palsy. You can see how the lateral 2 digits are flexed, while the medial 3 digits are, the lateral 2 digits are extended, while the medial 2 digits are flexed. That is partial. When it's complete, becomes an injury because of also contribution to the medial nerve palsy. But mainly, claw hand is injury of the ulnar nerve. Winging of the scapula, you can see medial winging and lateral winging. Medial winging because of injury to the long thoracic nerve. The most muscle that is most affected is serratus anterior. Lateral winging is because of injury to the trapezius muscle. You are unable to shrug your shoulders. So that will be because of injury to the spinal accessory nerve that supplies the trapezius muscle. This Ebb's palsy, you can see how that's the right arm is normally you adduct and you rotate, this medial rotation of the arm and forearm. Ebb's palsy. So that is it for the day. We want you to go through the brachial artery, the artery and veins, blood supply and venous drainage of the upper limb. Appreciate the thyrocervical trunk, how it divides into common carotid and subclavian artery, then which becomes the axillary artery, and finally the brachial artery. Know the branches, venous drainage, and the lymphatics. So at your own free time, describe the arteries of the upper limb, describe the venous drainage of the upper limb, describe the group of the axillary lymph nodes, and also boundaries of the axilla. Axilla means the armpit, so we want to know what are the boundaries. This anatomy can be very wide. If we really insisted on knowing every bit, you may never finish. But we just give you the must-know aspect of anatomy. Anatomy that will help you survive out there and become a good practitioner. So that is it for the day. For your practice questions, for example, MCQs of the shoulder and axilla, For example, which muscle forms the anterior axillary fold? I told you to look at the axilla. This question 2, the rotator cuff consists of all the following, except I alluded to that. You are able to see my screen, eh?
Yes.
Okay. Thank you, Ezra Ocheng. Which nerve is most commonly injured in anterior shoulder dislocation? Axillary nerve. We are just interested in knowing, do you know where axillary nerve is? The dilated muscle innervated by which nerve? Again, axillary nerve. Which artery gives rise to the thoracoacromial artery? Still the axillary artery, second part. The long thoracic nerve innervates which muscle? Talked about winging of the scapula, serratus anterior. These are very easy questions that I'll expect people to get out of. I don't know. They'll give us again 30 questions. People to get 30 out of 30. Which structure passes through the triangular interval? That one we'll know at your own free time. So you'll go through these questions. Go through questions wherever you can find questions. We'll not set questions from heaven. All this information should be in the slides. Which muscle initiates abduction of the arm at the shoulder joint? Supraspinatus. Which muscles of the anterior component of the arm is innervated by the radial nerve? You can see the answer. The answer is the brachialis muscle. But mostly it receives innervation by the musculocutaneous, but some branches. Yes.
We are not seeing the questions.
You're not seeing the questions?
Yeah.
Yes.
Who is seeing the questions? Oh, you are not seeing?
Yeah.
Okay, you will see them clearly in the exam. That is okay, right?
It's not okay.
Let me stop sharing first, then I share. Okay, we can start real quick.
Yes.
You can see now.
Yes.
Okay. We are asking about muscle that forms the axillary fold. Should know that the rotator cuff group of muscles, except one. Which one is not part of the rotator cuff? Which nerve is most commonly injured in the anterior shoulder dislocation? You must know that is where the axillary nerve is. So at your own free time, just do your own practice questions. But I will set everything that is within the slides. Which muscle initiate abduction of the arm at the shoulder joint? You should know that is the work of the supraspinatus. And see. The musculocutaneous nerve pierces which muscle? That one you must know. That it pierces the coracobrachialis muscle. Which area comes the radial nerve in the radial groove? Profunda brachii artery. The lower lesion of trunk of the brachial plexus partially affects which nerve roots? C8T1, Klumpke palsy. Which structure lies in the cubital fossa, medial to the brachial artery? You must know that. Medial nerve. Very easy questions, actually. Very easy questions. After mtaanguka tu. Now we have just talked about them. Which vein is commonly used for intravenous injection? The cubital fossa. That one is the median cubital vein. And lies superficial to the bicipital aponeurosis. That's what I'm telling you. You must know the venous drainage. Which nerve is at risk of midshaft humeral fracture? Normally that one is the radial nerve. So these are very easy questions. So you must make sure you understand the orientation of the anatomy, not just cramming. Use an atlas so that you are well guided. The median nerve passes between which two heads of the pronator arteries? Humeral and very easy. So we want to stop there and call it a day, but we'll meet next week. There was a bright student could be taking pictures of these questions. But a student who is not focused will just let the questions pass and pass so that they see them clearly in the exam. There are about 50. Okay, so next week on Friday, we'll meet and see. Maybe hope we'll create time. I want us to meet in the afternoon, 30 minute session, and look at the osteology of the upper and the lower limb. And then that's it for upper and lower limb. We finish anatomy then, right? Ama kuna kitu ingine itakuwa imebaki? Which system is remaining?
Pelvis.
Genitourinary system.
Genitourinary system taught by Dr. Ndiwa.
Endocrine.
So, in anatomy, there is endocrine. Huh? The syllabus is moving very fast. I don't think we have endocrine system in anatomy. Maybe in physiology and the likes. So that is it. You've seen the questions. So like this number 46, you've talked about it. The Ebbs Duchin palsy involves injury to which nerve roots? C5, C6. Kila kitu tumeongea tu. The cephalic vein drains into which vein? Any question? Any addition?
Yes, I have a question.
Yes. Masika Clifton.
There's a question I've posted in the charts.
Oh, you have posted the question. Just ask the question directly. I can't see it. Let me stop sharing first. Oh, it is here. I have a question on gluteal. Could you please explain the gluteal region? Superior gluteal artery, its two branches and muscle innervating. We have a question on gluteal region, and we are talking about questions for today. For upper limb.
Yeah. Yes, I'm a bit confused about that artery, especially the superficial one innervating. You said it's near the gluteus maximus.
Yes.
But when I use another source, it's saying a different thing.
It said it's innervating where?
The superficial branch, it said it innervates the maximus, and you said it innervates the minimus.
The superior gluteal, we say superior gluteal nerve.
Artery.
We talked about nerve. Nerve is the one that switched. Superior gluteal nerve innervates the gluteus minimus and medius, while inferior gluteal nerve is the one that innervates the gluteus maximus. But for the arteries, there is no problem. The superior gluteal artery will supply the gluteus maximus, and also inferior gluteal artery in some cases can still supply the gluteus maximus. But the inferior gluteal artery supplies the minimus and the medius. Which book was that? Again, you have to use a standardized book. Normally, we have anatomical variations. You remember in the sciatic nerve, we said ideally, under normal circumstances, the sciatic nerve should pass below the piriformis. But in some cases, we have the sciatic nerve piercing the piriformis or above the piriformis, or you can get the sciatic nerve coming out as two already, as having bifurcated into the tibial nerve and the common peroneal nerve, just even before it exits. However, in normal circumstances, the sciatic nerve branches into tibial and common peroneal nerve just above the popliteal fossa, at the apex of the popliteal, superior apex of the popliteal fossa. So there are anatomical variations that some books can consider, but use standardized textbook. Which book was that?
It was not a book, it was a confusion arising with your notes, because I was using your notes and they get
I will check and see if we are talking about nerve or artery.
It's the superior gluteal artery.
Let me go back and check. If in case of any issues, I'll communicate to the class rep. But you've gotten the point, right? Maybe I wrote nerve to mean artery or artery to mean nerve. I'll go back and check because I'm unable to do that right now in real time and answer your question.
Okay, thank you.
But you have understood the analogy, the reason why. I hope we said it's and muscle innervating. Muscle innervating what?
No, the vessels now the artery is muscles there.
Muscle supplying or innervating. An artery cannot innervate. Or what do you mean by muscles innervating? Huh?
I meant innervated by the artery.
You meant nerve supply.
I meant the muscles you mean
Pardon?
I meant the nerves being innervated, the muscle being innervated.
The muscle being innervated.
Yeah, by that artery, or being supplied by that.
A muscle cannot be innervated by an artery. A muscle can be supplied by an artery, but a muscle can be innervated by a nerve.
Yeah.
You get the point. Innervation means just nerve supply in simple terms. So the gluteus maximus is supplied by the superior gluteal artery. That is the blood supply. But for the nerve supply, or rather for the innervation, is the inferior. You understand now?
Yes.
Yes. For the blood supply is superior gluteal artery. In fact, even the inferior, both superior gluteal artery and inferior gluteal artery can supply the gluteus maximus. But for the nerve supply, that is blood supply, nerve supply, superior gluteus maximus is only supplied by the inferior gluteal nerve. Sawa.
Yes.
While the superior gluteal nerve supplies the tensor fasciae lata, the gluteus minimus, and gluteus medius. Another question. So when you talk about innervating, it cannot mean blood supply. No, innervating means nerve. There is the word nerve there in that word in the first place. Innervating. So that is nerve supply, not blood supply. Anyone with another question? Before we clearly see the questions in the exam. So the exam will involve the upper limb and the lower limb. I don't know when it is. We'll only set, maybe I'll only set 15 questions for the exam. And you maybe might set also another 15. We'll see when that time comes. But we'll only set what we've discussed. This kind of Ebbs palsy, clamp care, original insertion of muscles, cubital fossa. Those are the things we are interested in. The popliteal fossa, femoral nerve roots, sciatic nerve. So the issues that will insist in the exam must know. Make sure just for the arm, all the muscles, their original insertion, nerve supply. Sawa. We don't want you to fail. We want you to transition and go to the next category, or the next part of the academic progress, which is second year. At least fail those other ones, but don't fail anatomy, because anatomy is we are not even hiding. Questions are very direct. Very direct. So through the class rep, we'll communicate next week. I'll see whether we'll be able to do that session on the muscles, mostly the osteology aspect, so that you can get better orientation of what we are talking about instead of just having pictures. Any additions, any comments before we call it a day? Yes, Ochieng. Yes.
We have not received our GIT paper.
Mimi, I don't stay with the papers, bro. Me, I just mark papers and we finish and give back the papers. So we'll see. I'll liaise with the secretary, see whether you can get your papers, but you've gotten your marks, right?
Not yet.
Your marks are glaringly dangerous. I thought people will pass. I was even worried that people might pass to a point where the school might think that people got the questions beforehand, but it was to my dismay and surprise, people are just failing at will with impunity, so to speak. So you can liaise with the secretary maybe tomorrow at your own free time before it's lunchtime. Past lunchtime, mostly they get other engagements. So before lunchtime, link up with the secretary and get to see your marks and your papers as well. I'm not sure if they return papers or they don't return, but yes, just link up. You will get your marks. Or I can, during our next session, I can project your marks here. That is okay, Ochieng?
No.
Never.
You have a girlfriend in class, eh? Itachoma. Sawa. If you don't want us to, you just project your admission number. Who knows you? Or people know your admission number as well.
Wanajua.
Sawa. So see you in theater. Where do we meet? In the Anat Lab on Friday next week. We'll communicate the timelines, but tentatively from 2 p.m. We can start with which group wants to go first?
Nursing.
Okay, we can start with nursing first, then physiotherapy to come after an hour. We link with the class rep. Have a blessed day. This question, I'll just repeat this question projecting here. So hope you stay guided well. Good day.
You too.
You too, sir.
Nzuri.